Part of my presentation is going to focus on the care of stroke patients after they leave the ICU and they go to the acute care or stroke unit. We have found that there are better outcomes for patients when we have specialized stroke units, and this means that we have specialized nursing care, nurses who are familiar with caring for stroke patients and have specialized training. One of the major principles of acute care for stroke patients is focusing on early rehab. And this means getting early physical therapy and occupational therapy consults and collaborating with them. ADL training, which stands for Activities of Daily Living, is a major focus of our physical and occupational therapy and working with the patients early on so that we can start thinking about them going back home, because that's the ultimate goal, is to try to get our stroke patients back home. So a lot of times on these acute care stroke units, the nurses work very closely with the therapist and they get to know them very well, and they are educated by the therapists and other members of the interdisciplinary team of how to care for these stroke patients. And another major principle is managing spasticity. So this is a secondary effect of stroke, is that when patients have weakness in either their arm or their leg, it's one of the secondary complications is that muscle group becomes spastic. And nurses on these units work closely with the therapist to be able to help to intervene and manage these secondary complications, whether it be specialized braces for them, special positioning, or even sometimes medications. Next, I'm going to talk about DVT and PE, which stands for deep vein thrombosis or pulmonary embolism prevention. So with stroke patients, they're at higher risk for developing these secondary complications, and this is associated with increased mortality and morbidity. It's really important to know that this is oftentimes very preventable. So what we try to do is we aim for, as soon as we're able to start mobilizing our patients, when it's safe to do so, we want to get them out of bed and start moving so that we can prevent deep vein thrombosis. We also use medications to prevent DVT, such as enoxaparin or Lovenox or heparin. And so as soon as it's safe to do so, we will start patients on these medications. And this is typically just while they're in the hospital. They'll be started prophylactically on these medications. Certainly if they do, unfortunately, develop a DVT or a PE, they're going to be taking these medications after discharge. We also use sequential compression devices, or SCD. So these are, like, as you can see in the picture, the squeezing devices that can help to prevent DVTs, and also compression stockings can also be helpful. This is another very important prevention. For stroke patients, it's also very important that we identify patients who are at risk of falling. After a stroke, patients are certainly at risk because they may have weakness on one side of their body. And there's a lot of other reasons besides the weakness. For example, medications, if they're receiving any sort of pain medications, that could make them more at risk for falling. Just kind of the disorientation of not being in their home environment. We know that hospital rooms are small oftentimes, and there's a lot of different equipment in the room that they're at risk for tripping on. So it is really important that we have different assessment tools that we can identify that the different risks and triggers that patients may have that would put them at risk for falls, and that we also implement fall precautions. For example, you can see in the picture that patient has a yellow bracelet on, and typically yellow is the color that's used in hospitals to kind of identify that that patient is at risk for falling, so that other staff members can be alerted that this patient, and they may not know the patient, but they are at risk for falling. Intervention should match the risk factors, and also that we use all available resources for prevention. So using assistive devices. Another thing is that we also use different alarms in the hospitals. For example, chair alarms. If you have a confused patient and you have them sitting up in a chair, we'll put kind of a chair check that will kind of alert and let the staff know if that patient is standing up, and they probably shouldn't be, or we have different bed alarms. Another really important thing is that we try to encourage family to be present and with the patient, so that maybe they're a little less confused. So that's just a few examples of the different interventions that we use to identify patients who are at risk for falling, and then some of the different things that we do. Dysphasia. So up to half of stroke patients have dysphasia. And what this is, because of their stroke, they have weakened muscles that put them at risk for either aspirating. Excuse me, I'm going to start over. So dysphasia. Up to half of stroke patients have dysphasia, and what this means is that they have impaired ability to swallow, or the muscles that control swallowing are weakened because of their stroke. These patients have a really dramatically increased risk for aspiration pneumonia. So that's why it is very important that we assess their swallow. We have specialized tools that the bedside nurses use to evaluate whether the patient is safe to swallow. And if there's any sort of doubt or suspicion, then we get a formal speech evaluation by the speech language pathologist or the speech therapist. And these are this is the licensed staff that is specially trained to be able to identify if patients are at risk for dysphagia or difficulty swallowing. And if they have been identified, we'll do kind of temporary interventions. And usually with stroke patients, this does get better with time, and also therapy. And the therapist will do special exercises with the patients to help to strengthen those muscles. And we'll also do interventions such as doing texture modified diet. So they may need to start with a pureed type diet. And kind of as they start to get better and stronger, they'll advance their diet to more normal type foods. Malnutrition. This is another important secondary side effect to recognize with stroke patients. And there's a lot of reasons why patients are at risk for being malnourished. Like I talked about in the last slide, dysphagia, that they have impaired swallowing. Also, their mental status, if they're just too sleepy or not awake enough to take adequate nutrition. It's reported that about 50% of patients in the first 2 to 3 weeks after their stroke are malnourished. One of the things that we do is we initiate enteral feedings, which is either placing a small tube in the nose or doing the peg tube, which is the tube in the stomach, which is a surgical tube that's more for the long term. And we'll start giving them nutrition through that tube. But as a nurse, it's really important for nurses to closely screen that patient. For example, they can monitor their weight. So if you're noticing that your patient is losing a lot of weight, to closely monitor their intake and their output. And also in monitoring their blood counts. If their blood counts start to drop, that can also be a really sensitive indicator that their patient is malnourished. Another intervention is that we start giving them nutritional supplements, such as like high protein type shakes, or giving them a multivitamin to help with malnutrition. Next, I'm going to focus on bowel and bladder management. So this is a very important central aspect of stroke care, and this is also nursing assumes a major responsibility for assessing and managing these complications, because nurses are the ones who are at the bedside, 24/7, taking care of these patients. And one of the first signs is to monitor the intake and output and recognize if there is a potential problem. For example, if your patient hasn't used the bathroom in a long time, or avoided for several hours, you will quickly probably recognize that there is some sort of problem. Or also, these patients are at great risk for constipation. With regard to urinary catheters, this is a risk for infection. So it's not routinely recommended to just, if your patient hasn't used the bathroom for a while, to just put a catheter in them. We don't just routinely recommend because of the infection risk. Stroke patients are also at great risk for retaining their urine. So they're having a hard time controlling the muscles that allow them to void, also at risk for incontinence. So it's really important that the patient and the family are educated about this and the different interventions that we can do to prevent this. A lot of times, for example, with constipation, if you've noticed that your patient has been in the hospital for 3 days and they haven't had a bowel movement, then it's the nurse's job to let the physician know that, and we'll, order medications to make sure that they do go to the bathroom. Usually, typically, we'll routinely start giving these medications, but sometimes they need more. Promoting skin integrity. This is really important. Stroke patients are, like most hospital patients, are at risk for breakdown. Any bed-bound patient is at risk for skin breakdown. With stroke patients, they may have weakness or decreased sensation on one part of their body, so they may not feel that side as much and be able to tell the nurse that they're having pain or discomfort on that side because they have a loss of sensation from their stroke. So it's very important that nurses are constantly monitoring their patient's skin. At a minimum, nurses should be assessing their skin, and especially those areas that are more prone to breakdown, such as the bony area, such as their coccyx or their bottom or their heels. So they should be checking on that at least once every 8 hours. Hospitals will use an evidence-based assessment tool that they will use to document their skin assessments on. It's really important that nurses and other ancillary nursing staff are turning and repositioning patients at least once every 2 hours, especially, your totally bed-bound patients, the critically ill patients that are, have a weakness and are unable to turn themselves. We need to make sure that we're turning and repositioning them and moving them off those pressure points at least once every 2 hours. It's also, especially with your incontinent patient, that we're frequently checking and making sure they're dry, because if they're sitting in urine or stool, that is a major risk for skin breakdown. And also lastly, that we have different interventions that we can utilize products and different tools to reduce pressure reduction. So a lot of times hospitals will have special boots, as you can see in the top picture, that help to relieve pressure off the heel, and they're very soft and good for the skin. And there's different kinds of pillows and supports and different kinds of mattresses, even if you have a patient that is already showing evidence of skin breakdown. And lastly, depression screening. So this is for stroke patients. It's associated with poor quality of life and increased mortality. It is estimated that about 20% of patients who survive stroke have depression. And rightfully so. They have, this can be strokes can be very disabling to patients. Patients can lose the ability to speak after a stroke. They can lose control of one, side of their body. It can be very disabling, as I said. So oftentimes nurses are the first to be able to notice these depressive symptoms because they're with the patient all 24 hours a day. They're the ones that are talking with their patients, and the patients learn to trust their nurses. So a lot of times, they will tell the nurses, how they're feeling. So it's very important that we have special tools to screen for depression. And as soon as a nurse recognizes any of these triggers, is that they respond appropriately, that they're making sure that the physicians are aware that their patient has, told them that they're feeling depressed after their stroke. Another thing, it's really important that also family members and caregivers, the people who are caring for stroke patients, can also become depressed as well, because they their lives change dramatically too. They may their normal day-to-day living now may include caring for their loved one who requires around-the-clock care. So it's important that we as nurses are also making sure that we are monitoring our families as well, and talking to them and educating them and providing them with the resources that they need to be able to better manage and cope with caring for their loved ones after stroke. So this concludes part 3, the acute care management interventions for stroke patients.